Hi friends, this is Riddhi Joshi and today I'm going to talk about shoulder joint management. Let's see. First is painful shoulder syndrome that includes rotator cuff diseases, glenohumeral instability and impingement syndrome. So if we are in acute phase and we don't need surgery, so non-operative management. Let's see about this. Patient is in acute phase means maximum protection phase. So his presentation of problem is pain and inflammation, pain that limits range of motion, painful arc, positive impingement signs, muscle guarding and inhibition is there, internal rotation of glenohumeral joint, forwarded head posture is there. So for that reasons, what is the management? First management is patient should not do exercise that increase their pain, means they should not do pain provocating exercises, because if they are doing pain provocating exercises it limits their range. Then patient is in acute phase, so they have decreased range of motion, they have pain and muscle spasm is there. In order to reduce pain and muscle spasm of soft tissue, we are providing sling for their immobilization. Then patient use postural training exercise with the help of physical therapist, because if they have forwarded head posture and still they are doing exercise, so that increase their pain and we are not correcting forward head posture, so that is our fault. So in order to reduce pain and to correct their posture, postural training is necessary. With the postural training, their pain is reduced, their muscles are good, they are functioning properly and there won't be any limitation in range or pain. Then we are going for muscle setting exercise. So what is muscle setting exercise? Muscle setting exercise means low intensity isometric exercise with little or no resistance, because this muscle setting exercise it will prevent muscular atrophy as patient is in immobilization. So muscle atrophy is very common. In order to prevent this muscle atrophy, we are giving muscle setting exercises. Then passive range of motion to active assisted range of motion to self assisted exercise. Pendulum exercises. Grade 1-2 mobilization for pain relief and distraction. Grade 1 means small amplitude rhythmic oscillation at the beginning of range. Grade 2 means large amplitude rhythmic oscillation within the range. So that will decrease pain and spasm. For home exercise, pendulum exercise, we are providing postural correction exercises and gentle isometric in external rotation and abduction. Environmental modification is necessary because patient is in acute phase, and for that reasons if we are providing some environmental modifications in their home, so it will be beneficial for them. Now we are going to see about the moderate protection phase. In this phase, patient is having painful arc, muscle imbalance, decreased glenohumeral mobility, especially decreased mobility in pectoralis and minor and levator scapulae muscle. If posterior capsule contracture or secondary impingement is there, so glenohumeral internal rotation is decreased. If rotator cuff tear is there or bicipital tendinitis or scapular dyskinesia, then glenohumeral external rotators are weak. Scapular upward rotators and depressors are also weak in moderate protection phase, and especially decrease glenohumeral capsule mobility and they have pain because of this. So let's see the treatment in moderate protection phase. We can go for active range of motion exercise, grade 3 mobilization to increase the range, low load isometric exercise for rotator cuff and progress to weight bearing exercise. Then postural correction exercise at home, and to heal the tissues we can prescribe cross fiber massage. Especially workspace and ergonomic modification is necessary because patient is going for functional phase. After this phase and that's why we are providing them workspace and ergonomic modification. In return to function phase, patient is having neuromuscular control problem and strength is impaired. Especially their coordination is also impaired. So for that, grade 3 mobilization and stretching plus strengthening exercise, and they can go for plyometric and functional training. Plyometric prepare them for specific sports activity, and they can use the ball for this. Let's see the operative management for primary impingement and rotator cuff tear, rotator cuff partial tear. So first 0 to 3 week is maximum protection phase. In this phase, patient have pain, inflammation, muscle guarding due to pain. Hand is immobilized in sling, so limited range of motion, rounded shoulders, limited activity with affected side. So for this phase, patient should go for some activity in daily living exercise and while removing the sling and pendulum exercises. We should be having some precaution or caution, because to avoid the pain provoking exercise and monitor the incision site. If we are not monitoring the incision site and if it is open, then it will be more problem for patient. Then we can advise them to do some exercise like pendulum exercise at house, perform active range of motion on non-affected joint like cervical, elbow, scapula, etc. We can start exercise with active assisted range of motion in pain-free range. Example like wand exercise, gear shift exercise in sitting, etc. and low intensity exercise in protected weight bearing or close kinematic chain exercise. Do we think that this is helpful? Yeah, weight bearing exercise is helpful because close kinematic or weight bearing exercise is promote proprioception, joint stability, and especially that will activate muscle co-contraction around your shoulder joint, and that's why it is very important during maximum protection phase. Scapular retraction and thoracic exercise. Avoid active elevation beyond 90 degree, that excess weight bearing and exercise is also not provided for this kind of the patient, because still we are in acute phase. So we should avoid elevation beyond 90 degree and avoid excessive weight bearing exercises. Let's see about the moderate protection phase. It starts from 3 to 4 week or 8 to 10 week. Patient's presentation, they have still pain but increase with overhead activities. Healing is there, decreased muscle strength and decreased muscle endurance, limitation in activity in daily living. So for this treatment is start with the active range of exercise in horizontal abduction and adduction. Grade 2 and grade 3 mobilization we can give. Stop using sling because this is moderate protection phase, so we should start exercising. We should provide them home exercise program, because home exercise program is also necessary to improve their range, and in order to improve their activities also it is necessary. To start the exercise, external rotation exercise and tabletop exercise. Stretching is used to increase abduction, flexion and extension. Start with load high repetition exercise, especially with the biceps, deltoid and scapula stabilizers, and progress up to functional movement like carrying, reaching and pushing, because we are preparing patient for functional phase. In functional phase, it starts from 10 week. Patient presentation is patient is having full range of motion in the shoulder joint but problem with overhead activity for prolonged time. Therefore we should start first with the progressive resisted exercise and continue stretching of limited structures. We can go for plyometric exercise because it is necessary for sports specific training, and then Gradually we can start the sports related training with the high intensity overhead exercises, as it is relieved overhead activity pain. And then we can also prescribe them home exercise program like muscle endurance exercise and functional task, because if their functional task is not improved and they have to work, and that's why we are providing them functional task. Now we are going to talk about full thickness rotator cuff tear management. In 0 to 6 weeks maximum protection phase range of motion exercise we should start, and after removing sling we can do this range of motion exercise. For minimum operative repair, which is less than 1 centimeter, patient can start exercise from post-op day 1 or day 2. In minimum operative repair, if greater than 1 centimeter, so patient can start exercise in day 3 or day 4. Start with passive range of motion, then progress to active assisted range of motion. External rotation exercise is less than 45 degree in first 2 weeks because of operation. By the end of 6 weeks, external rotation should reach up to 70 and active range of motion exercise we can start. But we should be careful with the precaution in 0 to 6 weeks, like keep the arm below your shoulder level during active range of motion in scapula, because if you are keeping arm above the shoulder level, it may hamper patient's work, and especially there is operation, and it may affect the sutures also. Don't go for resisted range of motion exercise up to 6 weeks, because still patient is in acute healing phase. No internal or external rotation exercise in abduction in 90 degree for 4 to 6 weeks. We should not go for weight bearing exercise in post-operative shoulder. Patient should not do shoulder extension passed in neutral. We should start exercise with strengthening like low load high repetition, but don't start resisted range of motion exercise. Pain-free isometric exercise initially in non-weight bearing position, because it's a full thickness tear, and start with the close kinematic or weight bearing exercise after 8 weeks, and progress in different position, because weight bearing exercise is help for proprioception, joint stability, etc. We can do it in quadruped or push-up position. Resisted range of motion exercise we should start after 8 weeks. Till that time our patient's rotator cuff muscles will be repaired, and precautions like supraspinatus is repaired, so caution with resisted external rotation, and subscapularis is repaired, so take care with internal rotation. Stretching and mobilization start after 6 to 8 weeks. Start with the pain reducing grade like grade 1, 2, and low load and prolonged stretching we can give for this patient. Grade 3 for mobilization we can start at the week 6. Especially stretching like door frame stretching to increase rotation of the glenohumeral joint, corner stretch for pectoralis major muscle, and flexion and horizontal adduction at glenohumeral joint. Start plyometric exercise after 12 to 16 weeks, because at this time patient will start do some sport specific training. We should take precaution like if patient is repaired supraspinatus or infraspinatus. Supraspinatus is helping in abduction and infraspinatus is helping in external rotation. So if these two muscles are repaired, so avoid initial and range internal rotation exercises. Internal rotation we need to avoid because they are having suture in this area, means supraspinatus, and they have sutures in the infraspinatals also, so it may get tear. If the subscapularis is repaired, so subscapularis is helping you in internal rotation, means medial rotation. So if subscapularis is repaired, so at that time avoid end range external rotation stretching. If you are giving end range stretching exercise in external rotation, this subscapularis repaired is open. That's why we should not give external rotation exercise in end range if subscapularis is repaired. Avoid contract relax exercise up to 12 to 16 week. Pushing, pulling, carrying can be started after 12 to 16 week and with the sport specific training. Now we are going to see about the thoracic outlet syndrome management. So let's see about the patient presentation. Patient is having pain, paresthesia, numbness, weakness, discoloration and swelling. Upper thoracic breathing, like they have shallow respiration, compressed or stretched brachial plexus, first rib problem like decreased mobility of first rib, scalene, upper trapezius and pectorals are tight, rhomboid serratus anterior and deep neck flexors are weak. Like this way. Here we can see that tight upper trapezius and levator scapulae lead to forward head, inhibited deep neck flexors muscle and inhibited rhomboid plus serratus anterior muscle, and oppositely tight pectoral muscles. So patient is having functional problem like patient cannot sleep, they have sleep disturbances, problem with carrying suitcase, purse or briefcase on affected side. Patient can't maintain prolonged overhead activities. Even patient have problem with maintaining posture like holding phone, working on desk or prolonged driving. So these all are about presentation and functional problem. Now we are going to see about the management for these patients. Let's see non-operative management of thoracic outlet syndrome. The main concern for this non-operative management is to control the symptoms of thoracic outlet syndrome. So in early treatment phase like phase 1, we should first focus on the symptom reduction. So we have pain, paresthesia, numbness. So we need to address that symptoms and reduction before addressing biomechanical corrections. So first we can take patient for the cervical traction and hot pack treatment. So we can give them some light exercise that reduce their pain and irritability of acute patients. Especially we should give them the education like avoid exacerbation of symptom like forward head posture. They should correct their posture first. We should teach them diaphragmatic breathing exercise because some patients are mouth breathers. So because of that reasons they are using accessory muscle. So we should avoid using accessory respiratory muscle. We should teach them diaphragmatic breathing exercise. Accessory muscle respiration like scalene which elevated the first rib, and that's why we need to avoid that. Let's see phase 2. In this stage, therapy should treat the tissues that create a structural limitation of motion and compression, especially neural mobilization and first rib mobilization or acromioclavicular or sternoclavicular joint mobilization we can prescribe for this patient. We should stretch the tight muscle and strengthen the weak muscle. So levator scapulae, scalene, pectoralis minor and major we should stretch. We should strengthen the rhomboid, serratus anterior, lower and middle traps and other observed postural weakness. Like if the patient is having other postural weakness, we need to correct it. We need to teach some home exercise program for this patient because first rib and self mobilization is necessary with towel and stretching exercise with strengthening. As they are doing some exercise at home, so it will help them to recover fast. Let's see the post-operative exercise for thoracic outlet syndrome. First of all, we need to know about the precaution and avoidance of exercise in post-operative phase because it is recently operated, so it may harmful if they are doing excessive exercises. Let's see this. They should avoid weightlifting greater than 5 lbs in first 6 weeks. No overhead activities during 2 to 4 weeks. Immediately report if the patient is having swelling near surgical area. If swelling is there, that is not good sign. Immediately report to your surgeon if patient is feeling increased heat, redness, pain, drainage, dizziness, numbness, tingling, in hands, feet, or groin or low back pain. So that is new. And if this kind of the symptoms are there, so that is emergency, because some now is compressing or they are having some kind of problem with surgery. If symptoms last greater than 2 hours, that indicate that we should modify the exercise program. No strengthening exercise before 6 weeks, because up to 6 weeks that tissue is healing and it will take time to heal. In first week to 3 week, range of exercise like passive range of exercise, then active assisted to active range of exercise, neural mobilization and wound protection technique. Weight bearing after 4 week. Week 4 to 6 week, we can give phonophoresis on scar and start strengthening exercise after 6 week. As healing is completed, we can start strengthening exercises. Week 7 to 12, patient is returning to work, so we should go for ergonomic evaluation and body mechanics, like how their muscle are working. Is their muscle are working properly or not? Still they have forward head posture, or they have problem with first rib, or they are still mouth breather. Everything we need to check before they go for work hardening exercise or they return to work. After 7 to 12 week, patient can lift weight greater than 5 lb. Now we are going to see about recurrent shoulder instability, anterior capsule, labrum reconstruction, post-operative management. So first 4th week is maximum protection phase. So in this phase, patient is having immobilization with sling in bankart's repair. If bony bankart repair is there, so range of motion is delayed up to 6 to 8 weeks, because it's still healing. Due to pain, avoid prolonged internal rotation exercises. Start pendulum exercises as soon as possible after sling removable. Start passive range of motion to active assisted range of motion. If anterior capsule is repaired, limited external rotation, horizontal adduction, no active range of motion exercise up to first 2 weeks post-operatively. No active internal rotation exercise up to 6 weeks after bankart's repair. We can start low load high repetition isometric exercise from week 3 to week 6. Especially we need to take precaution, like no internal resisted isometric exercise or no internal rotation isometric exercise for open repair with subscapularis, as subscapularis is especially helping in our internal rotation. So if it is repaired, so we cannot give them internal rotation isometric exercises. In week 4 to 8, we can start with the close kinematic or weight bearing exercises after 6 weeks. This weight bearing exercise, it will prevent the joint instability and it will stable your joint. Weight bearing or close kinematic help patient for proprioception, muscle co-contraction, and that will start preparing your muscles to work. So we can go for partial weight bearing or tabletop exercises. We can start stretching exercise after 4 to 8 weeks post-operatively, because up to this time our muscles are healing and it will be provocating if we are doing this kind of stretching. For arthroscopic open repair up to 8 to 12 weeks, we cannot go for push and pull activities or external rotation activities. Like for an example, if we are putting coat or t-shirts, so that kind of activity we should avoid. If we are clasping the cloth behind back, buttoning or zipping, this all kind of activity is avoided in open repair up to 8 to 12 week. After 8 to 12 week, we can go for plyometric exercise. At 12 to 16 week, we can start that exercise. Especially recreational exercises and sports specific training. If the patient is like badminton player, so they should start with their exercises in 8 to 12 week or 12 to 16 week. Delay the high demand activity up to 16 week and delay weightlifting up to 12 week. Now we are going to see about posterior stabilization or reverse bankart repair. In this diagram we can see this is reverse bankart repair. Especially the posterior restraints are capsule, labrum and subscapularis. So avoid excessive stress on posterior capsule aspect. So after posterior stabilization or reverse bankart repair, we should take care of posterior capsule, labrum and subscapularis muscle. We should avoid range of motion exercises like active range of motion exercise up to 6 weeks post-operatively. We should not do internal rotation greater than 50 to 20 degrees. Avoid weight bearing up to 6 weeks. Avoid resisted exercise up to 12 to 16 weeks because it stresses your posterior capsule. Now we are going to see about the slap repair. So slap tears occur where biceps tendon and cause the labrum. So for this reason 2 to 3 week patient will be in immobilization in internal rotation. So we can only provide pain limited range of motion exercises. Especially passive range of motion exercise in first to 2 week and no external rotation greater than 15 degree and internal rotation should not be greater than 45 degree. After 8 week we can increase internal and external rotation exercises. Avoid lengthening exercise for biceps up to 4 to 6 week and bend exercise like hand behind back we should not give up to 6 week because slap tear occurs where biceps tendon and causes to labrum, and that's why lengthening exercise is avoided up to 4 to 6 week. So like patient is thinking that he should put his coat, so we should tell them you should avoid up to 4 to 6 week. Like isometric exercise we cannot give up to 6 to 8 week. After 8 week we can start strength training and isometric exercises. Now we are going to see about the mobilization. If we want to give flexion range improvement, we can give posterior glide. If extension limitation is there, if we want to improve extension, we can give anterior glide. For internal rotation, posterior glide. For external rotation, anterior glide. Abduction and elevation like caudal and inferior glide. So these all are about management and mobilization of shoulder joint.
Thanks for watching, and for future videos don't forget to subscribe. If you have any doubts related to topics in physical therapy exams, please let me know in my comment section so I can make a series of the videos on that. Till that time, stay positive. Bye bye.